All right, I think it is time to begin. So thank you everybody for joining us for our second virtual UCSF Division of Geriatrics Grand Rounds. I'm Louise Walter and I'm Chief of the UCSF Division of Geriatrics, and I'm really pleased to moderate this Grand Rounds today. So there's a few quick reminders before we get started. This meeting is being recorded, and as an audience member, your microphones have been muted. So if you want to ask a question, please submit your questions through the Q&A. We have disabled the chat function, so make sure you put it in the Q&A section, and we will address all questions at the end of the presentations. So today's Grand Rounds is titled Social Justice and Equity for Vulnerable Elders. Next slide, please. So this Grand Rounds is going to focus on 4 groups of elders who experience a lot of health disparities and disproportionately include minority elders. These 4 groups are older adults in prison, homeless older veterans, nursing home veterans with mental illness and dementia, and older adults living with HIV. For this Grand Rounds, geriatric faculty who are experts in these areas will discuss each group and address what are we currently doing to help these groups and what are next steps for social justice and equitable systems to really improve the lives of these vulnerable elders. So I'm now going to introduce the speakers. So Dr. Leah Rorvig is an assistant professor and geriatrician who provides care to homebound older adults and persons with disabilities in the UCSF House Calls program. She's also the director of health education for AMEND at UCSF, which is an institute focused on changing correctional culture to improve the health of those who live and work in US jails and prisons. Dr. Fabiny is a professor and the associate chief of staff for geriatrics, palliative, and extended care at the San Francisco VA healthcare system. She's also been instrumental in the development of an intensive supportive housing site for formerly homeless older veterans at the Colma Veterans Village. Dr. Michi Yukawa is a professor and medical director of the Community Living Center, which is the nursing home at the San Francisco VA healthcare system. Under her leadership, the CLC has developed several novel programs that provide compassionate and comprehensive care for veterans with mental illness and dementia. And Dr. Meredith Greene is an assistant professor and associate director of the Golden Compass program, which is the geriatric HIV clinic at Zuckerberg San Francisco General Hospital. She's a Paul Beeson scholar and nationally known for her research to improve the care of older adults living with HIV. So now I'm going to turn it over to Dr. Leah Rorvig, who is going to lead us off by talking about older adults in prison.
I'm going to be giving this presentation, quote, "I don't want to die in here, reducing the harm of COVID-19 on incarcerated older adults." And "I don't want to die in here" is a very sad quote from a letter written by a resident of a jail in the Houston area where there was a large COVID-19 outbreak. Next slide. Louise already reminded you that I'm a part of AMEND, and AMEND at UCSF transforms correctional culture inside prisons and jails to reduce the debilitating health effects of those environments on residents and staff. Next slide. So what are we going to talk about today? I'm going to tell you about 3 basic areas. I'm going to tell you about the impact of COVID-19 on incarcerated people, which of course has been tremendous. I'm going to tell you about our work on compassionate release, including what compassionate release is during the COVID-19 pandemic. And I'm going to tell you about our work educating community healthcare professionals about the rights of seriously ill incarcerated people. And just kind of taking a step back, what we have done during the COVID-19 pandemic is draw on our long-standing relationships with community members, correctional leaders, policymakers, all different types of advocates to really fill a vacuum for public health-oriented information about how to manage COVID-19 in jails, prisons, and detention centers. And it's kind of in that place that we're coming from to do this work. So let's get started. First, just thinking about jails and prisons in general. Next slide. But first, a case. So I want to tell you the story of a 71-year-old gentleman. He was incarcerated and he got COVID-19 in the prison where he lived. He was very sick in the prison and actually was intubated in the field and then transferred to a community hospital where he was held in the ICU. He sadly, this was a relatively large outbreak, and he was one of more than 20 incarcerated patients who was sick with COVID and then transferred to a community hospital. And he arrived intubated, but it was later found that he actually had a DNR order. Next slide. The community clinician was told by the prison that the clinician himself wasn't able to speak to this patient's family, and he also was not going to be allowed to arrange a goodbye video visit during the patient's planned compassionate extubation. And in fact, the community clinician was also told that the prison was going to tell the patient's family about the patient's death after it occurred. So, as many of you can relate, this community clinician was just absolutely panicking about the incredibly low quality and unethical feeling care that he was being asked to provide to this patient. So he reached out to us to ask, can you please clarify for me what are the rights of seriously ill incarcerated patients, and what can I do and what can be done to prevent this from happening to future patients? So just to kind of set the landscape for you, keep the case of this patient in your mind. Next slide, please. As a reminder, 2.2 million Americans are incarcerated. About 11 million cycle through jails each year. So we're talking about a huge group of people. Next slide. And 40% of incarcerated people in the United States are Black, and an additional 19% are Latinx. So when we talk about incarcerated people, we are automatically talking about people of color who are disproportionately represented among the populations of prisons and jails. This, of course, is due to institutional racism, which is a subject of another very important talk. But just to keep in mind, when we talk about incarcerated patients, we're talking about largely people of color. Next slide, please. For this audience of geriatricians, you all will be very interested to know that the number of older adults in prisons is very high and continues to rise. This graph shows the percent growth from 1990 populations of the general US population, the US prison population, and then the population of incarcerated people who are age 55 and older. And as you can see, the population in red, in the red line, of older adults in prison has been skyrocketing. And there's a few reasons for this, but the main one is that people incarcerated in the 80s, 90s, and 2000s have been in prison and are now, of course, aging in prison. And because of accelerated aging that has occurred due to incarceration, as well as accelerated aging that's been occurring for this population prior to their incarceration in the community, this population faces a very high chronic disease burden and therefore are at even higher risk of severe illness due to COVID-19. Next slide, please. Most of you hopefully know that COVID-19 has been absolutely catastrophic for incarcerated people, as well as people who work in prisons and jails. Just want to highlight this headline from the New York Times from June 16th. Coronavirus cases rise sharply in prisons, even as they plateau nationwide. Next slide. And the 5 largest COVID-19 outbreaks in the United States are linked to correctional facilities. So the graphic below that you see on my slides is our graphic from May 1st. And on May 1st, actually, it was nursing homes that sort of led the way in terms of the largest number of outbreaks and the largest single outbreaks. But over the last 7 weeks since May 1st, prisons and jails have very sadly taken over and are now the 5 largest outbreaks, including the single largest outbreak, which is an astronomical more than 2,000 cases, more than 2,300 cases actually, all linked to a very large prison in Ohio. Next slide. This slide turned out a little bit strange, but the number here should be 70,000. So there have been 70,000 COVID-19 positive tests among residents of prisons and jails. Next slide. And 627 deaths due to COVID-19 in jails and prisons. And I want to draw your attention here to the little graphic on the side of the slide, because these 627 deaths are not the deaths only of incarcerated people, but also includes deaths of people who work in prison, so correctional officers and correctional staff. Now, a prison is not like a cruise ship. It's not a little contained place that is separated from the community. Prisons are totally integrated with our communities, in particular because correctional officers and other staff are going into the prison, back into the community, into the prison, back into the community. So whatever's going on in the prison is actually going to be drawn back out into the community. So very important to keep in mind. Next slide. Now, many incarcerated people are newly eligible for compassionate release in the setting of this pandemic. Compassionate release is also called early medical release or medical parole. And these are programs and policies by which an incarcerated patient can get released early. Prior to the pandemic, this is largely used for people with advanced cancer. That's the most common application. But suddenly, in the setting of the pandemic, many incarcerated people are newly at risk of getting a so called terminal illness or experiencing significant morbidity and mortality were they to get COVID-19. So a large population of people are newly eligible for early release. Next slide. So we sprung into action to really try to protect older adults from the harms of COVID-19 in prisons. And the first thing we did was release decarceration policy recommendations, which are detailed public health recommendations, really designed to be used by lawmakers and correctional leaders to try to get people out of prison and jail before they get sick with COVID-19. Next slide. We also made this prognostication webinar, which is a 21-minute webinar about how to use prognostication if you are a correctional clinician to try to make the case that your patient should be released early from prison or jail. This has had more than 500 views on Vimeo as well as YouTube. Next slide. And then we also put together these compassionate release sample letters. And these are, as you can see from the front letter, this is a checklist letter that you can use to quickly download, mark off the boxes that are relevant to your patient, and then submit that to whoever is making compassionate release determinations at your facility. And then we took these last three things, so the decarceration policy recommendations, the webinar, and these letters. And these were, we collaborated with a national advocacy organization called Families Against Mandatory Minimums to put together a toolkit, which they then distributed to their partners. And they work with a large group of physicians and lawyers who are working pro bono to evaluate medical files of incarcerated people and hopefully get these people out of prison and jail prior to getting COVID-19. Next slide. We also, as sort of part of this package of activities, disseminated advanced care planning guidance for incarcerated patients. And as you guys know, as geriatricians, it's those same patients who are eligible for compassionate release who also need to have their advanced care planning addressed. And one big focus of that advanced care planning was actually emphasizing incarcerated patients' rights in ACP. For those of you who don't know, incarcerated people retain full rights to make advanced care planning decisions, including the right to appoint a surrogate decision maker. Next slide. So let's come back to the case, the really disturbing case from the beginning. So this was a case of a 71-year-old gentleman. He was incarcerated with COVID-19, intubated despite a DNR order. And the community clinician encountered terrible problems in caring for him. We stepped in and involved regional and national authorities in the correctional world to help with his care, legal experts, community advocates, and ethicists. And ultimately, this patient actually was able to have a goodbye visit, virtual visit with his family. And we were also able to get visits and increase communication for a small number of patients. But of course, what about all those patients who we never heard anything about and weren't able to help? Next slide, please. So a few lessons that we learned about protecting the rights of seriously ill incarcerated patients. First, community health professionals are not ready for this incoming deluge of incarcerated patients, but they need and desperately want information about how to care for them. And it's up to us to create a bridge between academic medicine and frontline stakeholders. And point four, we're really reliant on our community partners like Families Against Mandatory Minimums to actually disseminate this information across multiple disciplines. Next slide. So we're taking further steps around this area of protecting the rights of seriously ill incarcerated patients. We have a manuscript in development outlining the healthcare rights of seriously ill incarcerated patients. We're also developing a study to investigate community clinicians' understanding of these rights, which we believe are pretty poorly understood. Last slide. I want to say thank you so much to Bree, Cyrus, David Sears, David Cloud, and Dallas. We are the policy team at Amend, and please check out all of our resources related to COVID-19 in prison, jails, and detention centers at amend.us. Thank you.
Well, as you can see by my title slide, I have chosen to take a different approach than many of you might have anticipated in thinking about what I was going to talk to you today. And I want to say first, thank you to Louise for inviting me and giving me this opportunity. And I'm taking this approach because I really believe that in order to achieve social justice and health equity, that we need to do work ourselves in becoming anti-racist doctors, staff members, and leaders. And it also ties, of course, to the content that Michelle also just talked to us about. So next slide, please. And when I say one way forward, I want to make clear that this is simply my story, that each of us will make our own way as we embark on this work, and that a complex problem requires complex solutions, and the world needs each of us to do this in our own way. Sorry, I just need to move this so I can read this to you. So if you haven't read Dr. Martin Luther King Jr.'s letter from a Birmingham jail, I highly recommend it. I read it years ago, and I am quoting this for you because it really spoke to me. First, I must confess that over the past years, I have been gravely disappointed with the white moderate. I have almost reached the regrettable conclusion that the Negro's great stumbling block in his stride toward freedom is not the white citizen's counselor or the Ku Klux Klanner, but the white moderate, who is more devoted to order than to justice, who prefers a negative peace, which is the absence of tension, to a positive peace, which is the presence of justice. And I will confess to you that I saw myself in the white moderate, more devoted to order than to justice. And over the intervening years, I have really worked to change the way I think, find my blind spots, learn and listen and change. Next slide, please. And then my real hero in this work is James Baldwin. And again, I recommend to you any of the things he's written, but certainly The Fire Next Time, I would say, it's been the biggest inspiration for me personally. And I have several quotes from The Fire Next Time throughout this talk. The first is, to act is to be committed, and to be committed is to be in danger. So I certainly don't feel in danger here, but I will tell you that I am uncomfortable talking to you guys about this. I feel apprehensive. I'm worried I'm going to offend some of you. You're going to think that this is not appropriate. This is not the right forum. So that's just by way of saying that I have made the personal commitment to keep myself uncomfortable, because in my discomfort, I am able to see some of my blind spots better. I'm open to change, and I'm motivated to make change and be a little less fearful. Next slide, please. So I'm going to use most of my remaining time making reference to a document called White Supremacy Culture. And I will also say that I know that when some of you hear this or read this, that you will be put off by that expression, white supremacy culture. And I would ask if you could come along with me over these next however many minutes are left, and just contemplate that what white supremacy culture is really referring to is institutionalized racism and a white culture that keeps white people comfortable and white people safe and white people in power. And so that's what that phrase is really in reference to. And it comes from a website, Dismantling Racism, which I can also recommend. And it's a document. I have it printed out here, and I keep it on my desk. When I first discovered this, I think probably about 2 years ago, I printed it out and always kept it on my desk as a reference. I've given away several copies of it, and so have printed it out on multiple occasions. So because we all live in a white supremacy culture, these characteristics show up in the attitudes and behaviors of all of us, people of color and white people. Therefore, these attitudes and behaviors can show up in any group or organization, whether it's white-led or predominantly white, or people of color-led or predominantly people of color. Next slide, please. Here's James Baldwin again, as promised, and of note is that he was writing this in 1962, so clearly there's a wealth of literature and resources developed over decades to help us all move out of the place that we're in right now as a culture. It demands great force and great cunning continually to assault the mighty and indifferent fortress of white supremacy. Next slide, please. So the white supremacy culture document describes 15 characteristics of a white supremacy, of a white culture. And the wonderful thing about it is that, and I'm only going to highlight 2 of the 15 characteristics. And the wonderful thing about this document, and it sort of gets back to what Michelle was talking about, and I think some of the questions that people had is, what can one actually do? And the great thing about this is that there are antidotes to, or suggestions for ways one can change one's behavior as an individual that counteracts these, the characteristics of a white institutional culture. So I would guess that perfectionism is something that those of us who are successful, and that's everybody listening to this presentation, can recognize. So perfectionism in this context looks like little appreciation expressed among people for the work that others are doing. Appreciation that is expressed usually directed to those who get most of the credit anyway. It's more common to point out either how the person or work is inadequate, or even more common to talk to others about the inadequacies of a person or their work without ever talking directly to them. And mistakes are seen as personal. That is, they reflect badly on the person making them as opposed to being seen for what they are, mistakes. And I want to be clear that I have not offered up these examples as a way of saying anything about the institution or the division at all. These are from the document. So I hope none of you will think that I'm targeting you, because I am not. Next slide, please. And then here are 2 of the antidotes. Develop a culture of appreciation where the organization takes time to make sure that people's work and efforts are appreciated. Develop a learning organization where it is expected that everyone will make mistakes, and those mistakes offer opportunities for learning. And the people who work most closely with me will be able to know whether I'm speaking the truth or not here, but I've really taken it to heart that if you're not making mistakes, you're not learning. If you're not making mistakes, you're not changing. If you're not making mistakes, you're not growing. And I welcome mistakes and appreciate when people bring forward their mistakes. And just as an example of how that's one of the antidotes that has really I've been able to respond to and have changed my behavior over years, to really, really appreciate mistakes, and then also call out my own and ask people when I make a mistake and might not even see it to let me know. And I am very grateful to those who work with me who have called out my mistakes. And if all right, let's keep going. Sense of urgency, continued sense of urgency that makes it difficult to take time to be inclusive, encourage democratic and or thoughtful decision making, to think long term, to consider consequences. And this really gets to what Michelle was talking about. Sense of urgency frequently results in sacrificing potential allies for quick or highly visible results. For example, sacrificing interests of communities of color in order to win victories for white people. Reinforced by funding proposals which promise too much work for too little money, and by funders who expect too much for too little. And I imagine that makes sense to many of you in the audience here. Next slide. And my last quote from James Baldwin: "One can give nothing whatever without giving oneself. That is risking oneself." And the last slide, please. So the antidote is realistic work plans, leadership which understands that things take longer than anyone expects, discuss and plan for what it means to set goals of inclusivity and diversity, particularly in terms of time, and learn from past experience how long things take. And I have really used this, these antidotes around the sense of urgency to inform how I engage with the people who report to me about setting goals and setting reasonable goals and achievable goals and goals that make sense for them rather than necessarily comport to the institution. Then it's my job to run interference between these more humane, inclusive goals and the expectations of the institution. So that's just an example of how I've tried to put these actions into place. And with that, my time is up and I thank you.
Hi, good afternoon. I hope you can hear me, and thank you, Louise, for giving me the opportunity to share with you some of the innovative programs that we have been instituting in our community living center, people with dementia and mental health illness. So briefly, I'd like to kind of describe the demographic of older veterans, and then some of the existing program at the CLC, which is targeting patients with dementia and mental illness. And then to describe the COMC program. Next slide, please. Next slide. So this is a demographic of veterans, not necessarily in a nursing home. I actually had difficulty finding the demographic, but this is just veterans in general who are older, above 65 years in age. Predominantly they are Caucasian, about 78% in 2014. Hasn't changed very much in 2018. And then African-American veterans are about 12%, Asians about 1.8%, and Hispanic 8%, and American Indians or Alaskan Natives about 0.8%. Next slide, please. And this is the demographic of our San Francisco Community Living Center demographics. We have 61% of veterans are white, 24% African-American, 5% Asian, and 10% Hispanic. So as you're all aware, there's a growing number of U.S. Patients with Alzheimer's disease, and it is expected to triple by year 2050. Next. Studies of all nursing home residents find the prevalence of dementia is as high as 74%, and 90% of those with dementia may have behavior symptoms which may be able to be prevented. And next. In currently in San Francisco CLC, 64% of veterans have neurocognitive disorder. Next slide, please. How about mental illness among veterans? Actually, veterans over the age of 65, maybe 18% may have confirmed mental health illness and 25% possible mental illness. Next. Actually, the younger veterans have more of a confirmed mental health illness than older. And as you can imagine, the common diagnoses are depression, PTSD, anxiety, alcohol use disorder, and other drug use disorder. Next slide. So this is just a snapshot of the CLC veterans at the San Francisco VA as of December of 2019. So 64%, as I said, have neurocognitive disorder. 78% of veterans have mental health illness. And what I would like you to pay attention to is the last graph, which is 59% of our veterans have both neurocognitive disorder and psychiatric illness. Next slide, please. Well, these are some examples of programs that we currently have to help veterans with cognitive impairment, and even may help veterans with mental health illness as well. I won't go into detail, but I will highlight some of them. Next slide, please. Living the Moment is designed for veterans with mild to moderate dementia. So we discuss about past events because they tend to remember past events more than current events. But we do talk about some current events so that they can be thinking about what's going on. We do a lot of exercises as well as you can see, they do some artwork. Again, this is for mild to moderate dementia patients. Next slide. Plie, it is not a ballet move as some of my students who took that course says, oh, PLIE, you have a ballet program. But actually, no, it stands for Preventing Loss of Independence Through Exercise Program. This is a collaboration we did with Dr. Deborah Barnes. PLIE is a program that she has designed and implemented, but we partnered with her, and for the first time, the PLIE was conducted in a skilled nursing home. It has exercising component, many social engagement, music to improve moods, but this focuses really on ability of neural mechanisms that are still maintained within the individual rather than focusing on what has been lost. We try to capitalize on some things that they are still able to do. Next slide, please. The guiding principle of PLIE is muscle memory, practice movements to maintain daily function, and mindfulness, increasing awareness through in-the-moment attention to body and breathing, and meaning, promoting social and emotional connection through music and shared movements. Next slide, please. This program is very popular. I'm just sharing with you some of the quotes that the veteran has expressed after being in part of this PLIE program. They feel calm, they feel more energized, optimism, and even better posture. Next slide. As you can see from the side, it's very, very popular. It's exceeding my dining room capacity because there's so many people involved. The nice thing about PLIE, it can be enjoyed by people who have no cognitive impairment to somebody with almost very advanced dementia. You see family members enjoying as well as staff. Next slide, please. We also have a drumming group. It's very popular amongst the veterans because who wouldn't like to bang on something and take out their frustration? So it's again, very popular, therapeutic, and it can be for anyone with mild to even advanced dementia can join the group. Next slide, please. Snoozelen is an equipment designed by a Swedish neurologist to help calm some of the veterans who are agitated because of their underlying dementia. It's a very expensive piece of equipment that we were able to purchase, and we do use them to calm some of the veterans who are agitated. Next slide. Animal-assisted therapy. We do send veterans to an outing. Again, this is before COVID. We were able to take some of the veterans to the zoo, and you can see animal, live animal, and we have now changed to a virtual animal visit because of the COVID. And of course, they're very widely popular and very therapeutic for veterans. Next slide, please. However, unfortunately, despite all the wonderful intervention, there are more programming that we do have. We have seen there's increasing in number of patients with dementia and mental illness, which leads to increase in disruptive behavior, which has led to poor quality of life for veterans and also for staff. There is a significant amount of staff burnout that we recognized. Next slide. So as the World War II veteran and Korean veterans are passing, we are now seeing more Vietnam War veterans being admitted to the skilled nursing home. And we have seen that these young veterans, actually, there might be only 65, but have functional dependents that are similar to anyone with over the age of 80 having some function dysfunction. They tend to have lower levels of social and family support and personal finances. They tend to have more alcohol and substance abuse, and they have more PTSD. Next slide, please. So between 2017 and 2018, CLC was responsible for 45% of all the disruptive behavior reports that was filed. That's quite significant. 70% of them were physical disruptive incidents. Next slide. As you can imagine, that is very stressful for the CLC staff to deal with. And we conducted a burnout survey, Maslach burnout scale. And you can see from this data that not just nursing, but other interdisciplinary team members who experience significant amount of burnout from taking care of these challenging veterans. Next slide, please. So we knew that we needed to create some kind of new model to help take care of veterans with very advanced dementia, but also having mental health illness. Next. And next, please. And this is not unique to the San Francisco VA. There are other VA hospitals in CLC that are recognizing that this is a rising concern, that we need to develop a better program. Next slide, please. So there are other interventions that have been proposed outside of the San Francisco VA. Most famous is the STAR VA, which is a workshop to help CLC staff learn how to deal with patients with advanced dementia or how to behavior manage them. The Vision 23 VA has developed a behavior resource and outreach team called the BRO program. This allows the mental health providers from the VA reach out to contract nursing homes and other settings to help manage veterans with behavior issues. And there's other ones, but none of them have actually developed a program to manage veterans with advanced dementia and psychiatric illness. Next slide, please. Next. So this led to us making a program. We called it COMC program. It stands for Cognitive Ability Life with Meaning Complex. Next. This was spearheaded by Una Barnhart, who was our presidential fellow working in the geriatrics and palliative and extended care service line. This was started back in August of 2017 with dedicated committee members of interprofessional teams to try to develop a program to how best to take care of veterans, preserving their dignity and increasing the quality of life. So occupational therapist, who is our program coordinator, was hired in November 2018 to continue this work. Next slide. We actually obtained an IRB from UCSF to actually try to study this pilot program. And once the program is ongoing, it will be studied for a year. Next slide. So our target population, we went for the most difficult veterans that we are currently facing, is moderate to severe dementia and have a complicated mental illness. Next. They must have someone who is willing to give consent on their behalf, and they needed to have a disruptive behavior, at least one behavior note over the last month, or requiring 24-hour sitters to control their behavior. Next slide. The aims of the program is 1, to improve the care of veterans with moderate to severe dementia and mental illness, and 2 is to improve working condition and staff retention, and 3, reduce the frequency of disruptive behavior. Next, please. How are we going to do this? We surveyed our staff and they came up with 3 basic needs. You must have robust training, must improve communication amongst the staff, and to provide individualized care. So this is how we will do. We will be having a series of workshop and training sessions for the designated interprofessional team who will be taking care of these veterans. Improving communication by actually co-locating them in the same wing of the CLC and have consistent assignments so that the veteran will always see same team players. And we'll have frequent interdisciplinary rounding so that the communication amongst all staff will be readily available in a timely manner. Individualized care, there'll be a front porch and sensory room, which I will discuss shortly. Next slide, please. So this is just part of a mini program that our occupational therapist is trying to do to train our staff. Next, please. So the plan is for the occupational therapists and nursing to do daily rounds on these 10 veterans in our intervention group. And the full team will meet weekly. We'll be discussing what is going on so that we can maybe prevent any disruptive behavior from happening or any kind of risk prevention. Next. From porch is, you see a cart here. We actually have already purchased this. This is a kind of a recreational cart that a veteran can take part in at any time. as you can imagine, somebody with advanced dementia will not be able to participate in the group activities, but they can certainly do maybe individualized activities that our occupational therapists or recreational therapists might be able to engage them in. So this will be located in the nursing station area so that anyone can, any of the veterans in the intervention group can partake in these activities. Next slide, please. The sensory room is a calm, more home-like environment, and this is a room that a veteran can go if they're being triggered too much by or overstimulated by the CLC environment. Sometimes too much noise or too many people can be a triggering event for veterans with advanced dementia. So this is a nice room for them to have a little time out. Next, please. And lastly, it's a storyboard. This will be present in our interventional group. It kind of tells anyone that's walking into their room that these are some of the things that they were interested in, what they did in the past, their hobbies, their interests. So this could be a way for them to engage in a conversation with a veteran. Next slide, please. So expected first year outcomes is to reduce the rate of code greens or police assistance to try to de-escalate a veteran. Reduce hospitalization rate, as well as decrease injury, violence, or verbal abuse towards the CLC staff. And of course, decrease the number of sitters. Improve the staff knowledge of care of the complex veterans, and improve the staff satisfaction, which hopefully will reduce the absenteeism and reduce overtime costs. And of course, most important, patient satisfaction. Next slide. And potential long-term outcomes, I hope we will improve the overall health outcomes for our residents, reduce employee turnover, improve patient flow through our system, and improve patient and caregiver satisfaction. Next slide, please. As you can imagine, none of this would have been done without a lot of people's input, from nursing to other interdisciplinary team members of the CLC who worked tirelessly to develop this program. Next slide. Thank you very much.
Thank you. Thanks, Louise, for inviting me to be part of this panel. And thanks to all of my co-panelists, and also thank you for taking a chance. I think this has been a period of reflection, and I appreciate you taking the chance to do something different. I'm going to be taking the next 10 minutes to talk about older adults living with HIV infection. Next slide. These are my disclosures. Next slide. So very briefly, I'm going to talk about some of the epidemiology of HIV infection in the United States, and also very briefly talk about some of the work being done here at UCSF to support older adults who are living with HIV infection, because I want to actually take most of my time to talk about some of the lessons from the HIV pandemic response and how it can be applied to the COVID-19 response. And I'm doing that in part as a recognition of HIV long-term survivors awareness day this month, and as a reminder that for many of the older adults I work with, they have already survived a pandemic that was also caused by a virus for which initially there was no treatment and for which there is still not a cure. Next slide. So I want to start by briefly telling part of the story of Mr. H, focusing on his medical history. So Mr. H was a 74-year-old male who was diagnosed with HIV in 1984. And at the time he was interviewed, his HIV he felt was not his most pressing concern. He'd had an undetectable viral load for many years, but he was dealing with other conditions that were influenced by both having HIV infection and by some of the treatments for HIV infection. These include conditions like chronic kidney disease, osteoporosis, and he had been treated for anal squamous cell carcinoma. Because of his multiple conditions, he was also taking multiple medications, and he also had some unique social and economic concerns. So he quit his job in 1984 when he was diagnosed with HIV, because he was told he had 6 months to live. And here he was 30 years later. And he also noted that living in San Francisco in the 80s and 90s, that he had lost a lot of his social network to the AIDS epidemic in the city. Next slide. So Mr. H is certainly not alone. Right now, half of all people who are living with HIV in the United States are over the age of 50. And next slide. And basically 70% right here and now in San Francisco, 70% of people living with HIV are over the age of 50. So the majority of people with HIV in San Francisco are older adults. Next slide. Unfortunately, there are significant health inequities or disparities that are seen in HIV infection as well. This is new HIV diagnosis across all ages. But there's a similar trend amongst new diagnoses in older adults as well, that in 2018, Black and Latinx communities accounted for 69% of new HIV diagnoses in the United States, despite the fact that they only comprise 31% of our overall population. Next slide. And reflecting on some of the challenges that I described that Mr. H was facing, here at UCSF, we've been working to try to develop clinical services from the research we've done to support the needs of many older adults living with HIV. Right now, I do geriatric consults in 3 of the clinics affiliated with UCSF. That includes the 360 clinic and the Women's Health Program on the Parnassus campus, as well as at Ward 86 on the San Francisco General Hospital campus, where in 2017, we launched a new program known as the Golden Compass program, which was designed to try to adjust some of the challenges I described, some of the unique comorbid conditions, some of the geriatric conditions that occur, and address some of the unique psychosocial challenges that Mr. H was facing. And in a sense, because like so many, like Mr. H shared with us, that they felt unprepared to age, the program is designed around the 4 points of a compass to help older adults navigate their golden years. Next slide. But I want to actually spend most of my time talking about the lessons we've learned from the HIV pandemic. And I think we have to start by reflecting on what it was like in San Francisco in the 80s and 90s during the AIDS epidemic here in our city. And this photo is from the Gay Men's Chorus in 1993. If you look at the photo, there are 6 men wearing white shirts facing forward. They were the surviving members of the chorus in 1993. All the other men in the photo represent the number of members who died of AIDS. Next slide. And this is from an article published in Lancet HIV in April that talks about some of the lessons learned from the HIV pandemic and how we can apply this to the COVID-19 pandemic. And some of this, I feel like, unfortunately, history has been repeating itself. The first is to anticipate health inequalities. I already shared the health disparities that are seen in HIV infection. And unfortunately, we are seeing the same trend play out again during the COVID-19 pandemic once we began tracking the demographics of those who are affected. The second point they make was to support behavior change, you have to enable the environment. That includes having a systematic plan and response, including, for example, how are you going to have adequate supply and distribution of PPE? If someone doesn't have access to clean running water, how can they wash their hands? Those are just small examples. And then while coming up with a response, trying to avoid creating stigma around the illness. And if there's time in discussion, we can talk more about stigma related to HIV and what we've learned. And the third point they made was around multidisciplinary effort is critical. And this means involving the communities that are heavily impacted. This would include obviously older adults in the COVID-19 pandemic response. And also, I think this is another example of where geriatrics and infectious diseases can come together in this pandemic. Next slide. But the lesson that I have been thinking about recently is the tradition of activism that stemmed from the AIDS epidemic in this country because of the lack of the federal government response. And if you're not familiar with the organization ACT UP, I encourage you to read the article here that's referenced from the New York Times Magazine in April. And I think right now, as we're in this moment of witnessing a movement of Black Lives Matter and seeing protests in the street, I think it's really important to reflect on this tradition of activism and actually the lasting impact that ACT UP had on how clinical trials are run in this country, which is often overlooked. And the picture here is of Larry Kramer, longtime activist who passed away last month at the age of 84. Next slide. And we've had prominent activists, of course, here too in San Francisco, including Cleve Jones, who started the AIDS Memorial Quilt. The photo is when the quilt was unfurled on the National Mall in 1987. There were 1,920 panels on display, which is only a fraction of the 20,000 people who had lost their lives to AIDS. And in his quote, he talks about the need to reveal the humanity behind the statistics. And I think for all of us, the challenge here is, what is our role? How can we reveal the humanity behind the statistics from COVID? Next slide. I think we saw a glimmer of this when we had the front page of the New York Times. And I think in the face of ageism and also systematic racism in this country, I think I've really been thinking about how we can tell the stories and advocate for those who are disproportionately impacted by COVID-19. And there's been some work in the Kaiser Health News and in the Washington Post, but I'm anxious to hear what all of you think of how we can do this. Next slide. I want to end by sharing some of the promising collaborations, that multidisciplinary effort that I have seen take place, and some things that you can do. So Shanti was one of the first AIDS service organizations in San Francisco that mobilized volunteers to respond to the crisis. So when the Department of Disability and Aging Services needed to mobilize volunteers to support older adults, they partnered with Shanti in the SERVE program. You can volunteer for this program. If you need support, you can get support from this program. And you can also, if you have the ability, donate to the program. Next slide. Also in my role currently as part of the activation response with the Department of Public Health, our senior sites team has been able to partner with the Mayor's Office of Housing, who oversees the HIV housing sites, including the 5 residential care facilities for the chronically ill, and partner and share resources with the other residential care facilities for the elderly. Next slide. Also on a national level, this year marks the 30th anniversary of the Ryan White Care Act. And in August, the National Ryan White Conference is going to host the first Aging Institute to give voice to how services can be adapted to better serve older adults. And for the first time that I am ever aware of, the HRSA Bureau of Health Workforce, who sponsors our geriatrics, GWEP, and GACAs, is going to be speaking and talking about how they can collaborate with the HRSA HIV/AIDS Bureau that sponsors the Ryan White program. Next slide. Finally, I just want to talk about 2 local events that you can participate in or support in the coming month. The first is that the AIDS 2020 conference was scheduled to come to San Francisco and Oakland next month, normally bringing 20,000 people. In its place, though, we have a virtual conference and the first ever HIV long-term survivors and older adult networking zone that will be live between 1 and 3 p.m. every day of the conference. Next slide. And the final event is AIDS Walk 2020 that has been a huge supporter of the Golden Compass program and also a long tradition of activism. We'll be going virtual, benefits our GWEP partner, PRC, but 80% of funds raised go back to all the organizations that participate in the event. You don't have to fundraise, you can also just sign up as a virtual walker. And with that, I'm going to end, so we have a few minutes for questions.
Thank you, everybody, for the panelists. And we do have a few minutes for questions, so I thought I would, I'm going to direct my first question to Anne. Let me see if I see Anne Fabiny. There you are. There's a question from one of the audience members. Do you think meritocracy contributes to racism or exclusion and injustice? And if so, how?
Yes. First of all, it's a white definition, and it assumes a level playing field, and that all comers to science, and meritocracy is generally used in the context of science and scientific endeavor, that it assumes that all people have the same access to resources, and that those people who are the brightest make the best use of those resources. But of course, that's a false assumption.
Thanks, Anne. The next question is to Leah, Dr. Rorvig. Compassionate release, you talked about that. Oh, and you talked about prognostication. How much do other factors go into deciding about compassionate release? Does severity of the crime, or there's other things that go into it? Because certainly we hear a lot about the people who are very ill oftentimes don't get compassionate release.
Yes, certainly in general, consideration for compassionate release is given to those people who had a nonviolent conviction, which is obviously the vast majority of incarcerated people. However, I would like to point out that older adults writ large have a much lower rate of recidivism than younger incarcerated people. So even those people who have served a term for a violent crime potentially would be eligible for compassionate release, because if someone's already served 30 years, perhaps, that they were sentenced for a violent crime, we can consider that time served. And if their time is supposed to be up in 6 months, I would say we should release them now before they get COVID-19, particularly given this excellent data of low recidivism among these older incarcerated people. Very good question and common public concern.
Great. And then Meredith, you mentioned about stigma and HIV and how that might be a lesson for us in terms of stigma around coronavirus in our vulnerable older population. Can you say a little bit more about that?
Yeah, so I think first is that language is really important. There's a reason why I always say older adults living with HIV, and I try not to, even though I'm a clinician, say the word patient, because that just carries a more connotation of disease. I will say it doesn't help when people are calling a virus a Chinese virus. Viruses don't have nationality. I think that's contributing to, unfortunately, to some of the stigma right now. So I would say language, and I would think, and also just having a conversation and acknowledging that there is stigma associated and trying to normalize and talk about someone's concerns, what is underlying that stigma.
Great, thanks so much, Meredith. And then this will be just the final question I'll ask each of the panelists just to give your thoughts on is, what's one thing, the audience members could do to advocate for vulnerable elders during this critical time? Is there one thing either that you think for the population that you're working with, or just in general, that you might recommend that audience members think about doing? I know many of you included that, but just put it out there. And maybe I'll just go in the order of the folks in terms of presentation. So Leah?
I mean, I think I would actually give two pieces of guidance. One, don't forget that there's a humongous population of incarcerated people who are at sudden risk of receiving an inadvertent death sentence, if you will, if they get COVID-19 and get seriously ill. I think the second action is really to think about your role as a geriatrician. And as geriatricians, we really need to be interfacing with these community clinicians who are going to have to care for incarcerated older adults when they are sent to the hospital, and then develop delirium, need palliative care, and need other assistance, which directly we can help with given our skill set as experts in the medical care of older adults.
Great. And Anne?
And I would say pick a topic and learn and listen.
Great. Michi?
So in light of the COVID infection, I know there's a lot of people, disproportionately the skilled nursing home veterans or patients are dying. So I guess I'm being very careful about who comes to visit, but I guess they are very lonely. So if there's ways that you would like to donate your time to do iPads or any kind of a one-on-one interaction with the veterans who are very lonely and and isolated. If you have time to do that, we will welcome that.
Great. And Meredith.
And what came to my mind is giving voice. So telling the stories, listening, sharing the stories of those who have been affected. And I would say many older adults with HIV feel invisible because they're confronting multiple stigmas. And I think if you can help advocate in that way by telling other stories.
Great. I think that's a good way to end this grand round. So again, thank you all for participating and thank you for joining us. And the grand rounds takes a break over the summer, but we'll be back in the fall. So thanks so much, everybody.
Bye.
Bye-bye.